Not all AI is going to save you time. Not all AI is going to work. Not all AI is going to merit clinical application. And when you pick up a journal, I hope it's JAMA or one of the JAMA journals, but even if it's one of the others, or when you hear on the news about, this amazing new AI innovation, I think look at the fine print and look for clinically meaningful measures. Does it change patient care in a meaningful way? Does it change quality of life in a meaningful way? Because it's great technology, and like any other technology, sometimes it's useful and sometimes it's not. And sometimes it's harmful, and that's what we're coming to grips with now.
This is the Visible Voices podcast, and I'm your host, Dr. Resa Lewiss. Today, I am so glad, audience, to be joined by Dr. Roy Perlis. Roy is the editor-in-chief of JAMA, that's the Journal of the American Medical Association, plus AI, or JAMA AI. This is a 2024 relatively new journal responsible for AI content across the entire JAMA network. Roy directs the Center for Quantitative Health at Massachusetts General Hospital and is vice chair for research and an endowed chair in the Department of Psychiatry at MGB. That's Mass General Brigham in Boston. In other words, Roy is a psychiatrist, a researcher, and not just any researcher, but someone that's been doing work in the AI space since college, which, by the way, is where we met. Roy, welcome to the Visible Voices podcast.
Thanks so much, Resa.
The goal here is to help inform our audience and help explain a little bit of AI in healthcare for them. Given that you are editor-in-chief of JAMA AI, I want to talk about how you introduced the journal, which was Hello World.
So thank you for noticing. That was a little bit of an inside joke, although hopefully one that people in the computer world would get. Traditionally, when you learn a new programming language, the first program that you write is something that prints Hello World to the screen. So in the course of many years of programming in BASIC and then Pascal and then C and C++ and whatever, pretty much the first thing I learned to do in each language was Hello World. So it seemed right for JAMA plus AI.
I just had a throwback Thursday moment, even though it's not even Thursday. I learned to program in BASIC. That's really funny.
Yeah, for me, I think I was about 10 or 11. And, I'm still terrible at writing code, as we might talk about. Fortunately, AI has sort of saved me from my own lack of skill in that department. But it is interesting to think of how different it would be to learn something like that now.
So, Roy, in your editorial, which, by the way, I loved, you highlight 5 main pillars or 5 main thoughts as a thought leader in this space. I'm wondering if you can go through these with me and the audience. AI is here. We know more than we think. Bias is a problem. There's a translational valley. And finally, we're going to be responsible, and we're going to be hearing more about policy and education.
Sure. So one of the things that I think is challenging with a new channel like JAMA Plus AI is that we're speaking to such a broad audience. And I think that's by design, right? So I don't want it to just be the sort of thing that's read by AI experts. But by the same token, I want it to be something where if you are an expert, it is still interesting to you. We're not just sort of speaking the obvious. And that editorial was really an effort to lay out, like, here's where we are. Here's my take. Where I think we are is that, first of all, AI really is here. It's not sort of around the corner. It's not something that's going to happen next year. I think the best example of that at the moment is ambient scribes, which maybe we'll talk about a little later. I think it's really important that people understand, especially people in medicine, but also patients and families, that it's not magic, and that all of the same skills that we would bring to bear for any other new treatment, technology, test apply to AI. And so really what we're entitled to say is, like, is this useful? Is this doing something that is improving patient care? And I think those were sort of 2 critical points. And then, the subject of bias, which might seem really specific, I think my fear is that because these models are trained on health data, huge amounts of health data, we're at risk for just sort of translating our existing biases that sort of make their way into care into our model. So the worry was that, as we develop these tools to assist with decision making, to triage patients, to estimate risk, we may end up with models that treat different people differently, that work better for some people than others. And the solution there is not to just throw them all away. It's to pay attention to the bias and to do what we can to fix it, to address it.
At the end of the day, this is about safer, better patient care. And that's what it's all about. You're a psychiatrist. And I think people are like, wait a minute, a psychiatrist is the editor in chief of an AI journal.
So sometimes people assume that because I've done some work on AI specifically in mental health, or even on the AI, on the consequences of AI for mental health, that that's how I kind of come to be leading the channel. But really, my work with electronic health records sort of spans areas of medicine. And I really do like to think of myself as a generalist. So I have collaborations with cardiologists and with the OBGYNs and with the internists and the surgeons. And I think it's really important to sort of have a broad perspective. So as a psychiatrist, I do think it, of course, impacts how I think about these tools and how I worry about their impact. But when it comes to the channel, I'm really, I can't just focus on mental health. And one of the things that we've really pushed for is to ensure that if you're an orthopedic surgeon, if you're an ophthalmologist, if you're a cardiologist, if you're an OBGYN, there is interesting AI. It may be in very different places. We might talk about the fact that different specialties are really different in how they've adopted AI so far. But we really have to be broad. We can't just focus on any particular specialty or domain.
100%. I mentioned in the intro that you've been thinking about and in the AI space since college.
It's true. When I was at Brown, I took courses with Gene Charniak, who was one of the early pioneers of AI. The area of AI I was most excited about was actually neural nets, which at the time computationally were really hard. I remember working my senior year on a model that had one neuron. It was a computational model of one neuron. We ran it on this big Spark station, this big fancy computer, and about half the time it would just crash. I do think something that's important for the audience to realize is a lot of the math behind neural networks, a lot of the sort of concepts really do go back decades. The two things that changed were, one, compute power, right? Like we can just build these neural nets at, orders of magnitude bigger than we could back then. And data, the internet really did provide, it's not necessarily good data. It's often actually really terrible data, but we have a ton of it. And in my opinion, those really are the two technologies or the two developments that got us from, 30 years ago at Brown to 2026 in terms of AI in medicine.
In emergency medicine, AI has reared its head. You mentioned certainly ambient scribes, also in terms of triage and triage scores with accuracy, and also in terms of pulling important relevant data from the electronic health record for that specific emergency department visit. Now, I have a note here about your lab and the research work you've done, which is pioneering work involving AI and large data sets. In 2016, you, your team, and your collaborators were part of discovering the risk genes for major depression. In 2023, for treatment-resistant depression.
So I, in many ways, started working with electronic health records in my research because we were running out of samples to do genetics. So I wish I could say, I had this vision that health records were going to be important in research. For me, it was just, we've used all the we've studied all the samples from people with depression that have been collected. How can we get more? And had this idea, now people talk a lot about biobanks. At the time, biobanks were really sort of nascent, like the idea of this large group of samples tied to clinical information was fairly early. And so my thought was, could we define depression in a reasonable way using health records? And then subsequently, could we define treatment response, which was really what I was most interested in. I was sort of trying to get past the trial and error in choosing treatments. So that's how I landed in electronic health records research. And the effort that culminated around 2016 was simply a numbers game. What we learned in genetics, at least in psychiatry and a lot of complex diseases, is it's a numbers game. You just need as many samples as possible. Now, the flip side of that, unfortunately, is I'm not sure what we have to show for our investment in psychiatric genetics. And that's not a very popular perspective, but I do think for all the money that's been spent chasing genes, we have exactly zero new treatments in psychiatry. So while we can't go back and do the experiment, I wonder if we'd invested in other technologies and other areas, if we'd be in a different place in psychiatry. But the good news is, I think identifying those genes does start us on the road towards better biology. And that intersects with AI because now maybe we can be smart in using some of the new tools we have on the AI side to help drive drug discovery or treatment discovery. So I'm hoping that sort of two halves of my research life, the wet lab that does genetics and cells and the dry lab that does AI and informatics, can finally work together.
I mentioned stigma. I grew up in a small town and people never talked about mental health, seeing a mental health professional. And even college to med school to residency, there were people training in medicine, doctors, and then there were psychiatrists and therapists. It was sort of this sidebar, different group of people, community. When I moved down to New York City, and as I started speaking with more healthcare professionals from San Francisco, I would say San Francisco and New York City were two places where the stigma didn't seem to be there. People are like, oh, yeah, I'm seeing my therapist. Or, oh, yeah, I'm on this med for my depression. And I wanted to ask you where you think we are today with the stigma of being a mental health professional going into psychiatry.
I think we're in a better place than we were 25, 30 years ago, certainly. I think people talk about it more. I think it helps that celebrities and athletes and other sort of high profile individuals,
And physicians.
politicians, um, and physicians talk about their own experiences. So I think that that's really critical. But I still think there's a sense that psychiatrists are weird, and there are folks where, med school didn't really work out all that well and they wanted to get away from it. They didn't like the sight of blood, or they didn't like all that, medical stuff. And I think it's really unfortunate and scares away a lot of people who I think would be outstanding psychiatrists. When I started talking about psychiatry, had a number of senior colleagues, mentors, who told me I was wasting my career. A dean, um, a leader in neurology here at MGH, people I respected, who said, why would you do that?
Yeah.
Why would you waste your medical skills on something that's so touchy-feely? When I was doing a sub-internship in neurology, because I still hadn't made up my mind, very senior neurologist looked at me down the table and said, "I've been studying the brain for 40 years and I have yet to see the unconscious." Um, and, it's hard as a med student. It's hard to push back on that. I really didn't make the decision until very late in the game. I did it because, first of all, I loved the patients. I just loved that clinical population. Those were the diseases that I cared about. I also saw, people suffer tremendously with these things, with these illnesses. And, I felt like it was a worthy use of one's life to try to work on that, even a little. I remember I asked someone who went on to be a leader in the field, do you think there's going to be neuroscience in psychiatry? Um, because I was a neuroscience major at Brown, this was always what I wanted to do. And he said, "You're making a bet that at some point in the future, there will be a neuroscience of psychiatry." And I'm really glad I made that bet.
Circling back to my stigma question, I have seen in healthcare professionals, in physicians, that the stigma has dropped a little bit. I think COVID did it. I also think the increasing publication of the numbers of burnout, moral injury, and dying by suicide. I'm an ambassador for the Dr. Lorna Breen Heroes Foundation. And just briefly, Dr. Lorna Breen, emergency physician, New York City at Columbia, she was a colleague friend, and we sometimes overlapped on shifts. And during the pandemic, she died by suicide. And part of it was her concern with the stigma of having to put it on her medical license and applying for privileges at a hospital. And my friends that are in program leadership, program residency directors, that they also share that it's better. The questions are changing state by state, license by license, but we're not yet where ideally we would be to be able to sort of physician heal thyself, physicians take care of themselves as well.
I think her story and the circumstances you describe are unfortunately so common. And it's interesting. I know physicians who will very capably diagnose and treat depression who won't seek treatment themselves. Um, because of the stigma, because of the concern about the implications for, having to disclose something um, on their license renewals. I mean, I- it's again, I wouldn't think twice. People wouldn't think twice about, oh, I have hypertension. I take medicine for hypertension. There is still something about psychiatric illness where people feel like it somehow doesn't merit treatment. And I do think people are a little more comfortable now talking about therapy, which is wonderful. I think, therapy for the right kind of therapy for the right person makes a huge difference. But I also want to recognize it can be costly. It can be hard to access a good therapist. And so for some people with things like depression or anxiety, medications make a huge difference. And again, it's ridiculous in 2026 to have to say this. I think implicitly there's still a sense that if you need a medicine, it's a moral failure, that somehow you didn't work hard enough or you're taking the easy way out. And I think that's just preposterous. It's just absolutely preposterous. But that is, and part of the problem when you say stigma, the stigma has sort of gone underground,
Hmm.
but it's still
Hmm.
there.
So, talk about exposing stigma or people able to channel what they feel may be stigma. AI chatbots, whether it's the physician talking now to a chatbot or even patients in mental health crises. What are your feeling on the role those chatbots positively may serve? And also, there's been stories in the news about how negatively people have gone down to places, dark places that have not had positive outcomes.
When chatbots first emerged, the sort of modern language model driven chatbots, I cold called the CEO of a company that was developing these. And I said, this could be an incredible tool for delivering CBT, cognitive behavioral therapy. This could be, forget the sort of more general psychotherapy. Like this could teach people principles of CBT, which would be really helpful to them. And we talked a little bit, and then he he's building a company, got busy, went on with what he was doing, and then called me about 3 months later and said, Dr. Perlis, I'm very worried. People are using this for things that we didn't think they were going to use it for. And I said, let me guess, they're using it for pornography. He said, yeah, we knew that. We knew that. People are also using it for pretend boyfriend and pretend girlfriend. Do you think that's okay? And that was really my first inkling of kind of what we would be contending with. I still believe that chatbots can help to address this incredible shortage of psychotherapists that we have, good psychotherapy. Um, I worry that they'll be used to keep people from getting individual psychotherapy because I worry very much that the insurers will say, well, have you failed a trial of this chatbot or that chatbot? So that's part one. But I think that with the right constraints around them, with the right sort of prompts and content, I do think it's a really effective teaching tool. So I think we haven't gotten there yet because I think we've been sort of distracted by the sort of supportive pretend psychotherapy that they can deliver. In terms of the flip side, the chatbots do dangerous things. Um, that's in my own kind of thinking about chatbots and sort of trying to understand how to use them. That's where I've gotten really interested is on the safety side. I think it's fairly easy to fix a lot of the really obvious things that were getting people in trouble. So a chatbot should not tell you how to harm yourself. It should not give you, instructions for how to harm somebody else or, do other things that could be unhealthy for you. That I think is not so hard, but some of the more subtle stuff. So for example, I think there's the easiest way to solve the problem of chatbots not telling people harmful things is to have them just end the conversation as soon as someone broaches suicide. To me, that's equally or it's at least similarly dangerous, right? Someone's just disclosed these really upsetting thoughts. And the first generation of chatbots would say stuff like, I'm sorry, I can't talk to you about that anymore. Some of them would even hang up on people. So that, I think, is the area where we have a lot of work to do. Is like, what is a therapeutic response? What should a chatbot do? How do you encourage someone to get help without hanging up on them?
A colleague friend was working an emergency department shift. A patient came in having overdosed on a medicine, and just to refresh himself, he wanted to know, how to treat an overdose of certain medicine, and quickly went into the chatbot, and the chatbot became concerned for him, the physician. He's like, no, this is a patient. I'm a physician. And, I'm not convinced. You have access to other resources. Do you need me to call 911?
Yeah, it's, we're getting better. I mean, I do think that the fact that this has gotten so much attention is important because it is something people are worrying about. Um, the other area that I'm worried about with chatbots and with AI in general is this sort of over-engagement or overuse phenomenon, which candidly we already knew about from social media. I think this is a lot like social media, right? It is addictive for some people. And this is the thing, again, with social media, some of us can take our phone out and flip through Instagram for 5 minutes and get on with our day. And some of us will spend hours on Instagram and we'll see things that make us more depressed or anxious. And probably, social media is not the best for those people. And I think AI is similar. What we've seen in our own work is a relationship between this sort of personal AI use and depression. Small effects in most people, really no effects in most people, but they're probably a vulnerable subset. And I would love to see on the research side a better idea about who those vulnerable people are.
Have there been research studies looking at brain imaging, what lights up when people are actively engaging with the AI?
I think people are doing those studies. I think it's rewarding in the same way that social media is. I mean,
Yeah.
that's the thing, what's remarkable to me is how, whether it's drugs or alcohol or other pleasurable things or social media, it's an old reward circuit. And
Yeah.
for many people, they can enjoy things and not have a problem. And for others, it becomes an addiction.
You talked about workforce and a workforce shortage, specifically in psychiatry. I looked at the recent residency match numbers, and psychiatry had a fill rate of 97.4%. And not to be sort of misguided by that number, 65 positions remained unfilled, which reportedly is up from 8 last year. What are your thoughts on the future of the psychiatry workforce?
I worry a lot about what the next generation is going to look like. I mean, I hope I gave this sense earlier, but I mean, it's incredibly fulfilling clinical work. I mean, it is really, people come tell me stories. They tell me about what's going on in their lives, and I try to make it easier for them to live their lives and maximize their function. So clinically, I mean, I don't know why anyone would do anything else, although I'm a little biased. Um, Unfortunately, so psychiatry loses money everywhere. My department loses money. The hospital's response is stop losing money, and we're sort of like those old .com things where like we lose money on every patient, but we try to make it up in volume. It's just the nature of the contracts that support psychiatry that if financially we just don't invest in taking care of people. And so I think more and more of psychiatry will be done by other than psychiatrists. So I think more and more psychiatry will be NPs and PAs. I think on the psychotherapy side, you'll see more social work, and to some extent psychologists, although more and more social work, where I think we'll have to learn to live with fewer psychiatrists, and there will be more pressure for psychiatrists to do what we as physicians can do that others can't, which is prescribing. So more
Mhm.
psychopharmacology. I do think decision support tools, so we've said a lot of sort of worrying things about AI. I think decision support will make it possible for us to be much better prescribers and sort of spread the expertise out. So, anyone in clinical practice can have access to the expertise of someone who focuses on treatment-resistant illness, for example. So that's an area where I think AI will go a long way to actually help us despite the workforce problems.
Roy, when did you realize you had a voice and when did you start using your voice?
I guess I would say two things. I never realized that I liked talking in front of people. I'm kind of shy. I never wanted to be the one, I didn't do talent shows. I had a little bit of a speech impediment when I was a kid and I couldn't even say my name. So I said W's instead of R's. And I think that's how, so I, you know, I would tense up when I had to introduce myself, but I learned as a fellow that I liked talking about science. I liked getting up and talking about whatever. And so that was kind of part one. And then part two was with my work in AI and my work with JAMA. I've been thinking about this stuff for 25 years. And all of a sudden, people care about this thing that I've cared about for a long time. So I think it has been another opportunity to use that voice a little bit differently. And just like with your show today, it's an excuse to talk about both AI and mental health, right? So, I will get my foot in the door because we want to talk about AI, and then I will pivot and talk about mental health, which is something I also feel strongly about.
Healthcare and AI seems like a large, overwhelming goal, task. And for the healthcare professionals that are listening to our conversation today, what are 3 concrete actions, 3 behaviors they can take today to more meaningfully engage with healthcare AI?
So the first one I would encourage people to do is to pay attention to how much time they're spending on various tasks, whether it's using AI or documentation or whatever. I think there have been a bunch of studies that suggest that people will say that ambient scribes decrease the amount of time they spend in documentation. And then when you measure it, it decreases their time on documentation by almost nothing, by a few seconds to a few minutes. So the first thing is actually pay attention, be mindful about like what am I doing during the day? And the corollary to that is of the things I'm doing during the day, what would I like to do more of? What would I like to do less of? So for me, for example, documentation, as much as I worry about scribes, I found that that was the part of my job that I enjoyed the least. And I think that's probably true for a lot of clinicians. So micro skill one is just notice, be mindful of what you're doing during the day, because it might surprise you. Number two is play with AI. Whether get one of the $20 a month subscriptions if you can, or get your employer to get you a subscription to one of them. Really get comfortable with what they can do and what they can't. I think there's a lot of myth about both the strengths and the challenges of like using Claude or using ChatGPT. I now find that in my work as a scientist, I spend a ton of my time with those tools. And I think the only way to get comfortable with it is to put your hands on it and just start playing around. I don't know if this counts as a micro skill, but the third thing is be skeptical. Not all AI is going to save you time. Not all AI is going to work. Not all AI is going to merit clinical application. And when you pick up a journal, I hope it's JAMA or one of the JAMA journals, but even if it's one of the others, or when you hear on the news about, this amazing new AI innovation, I think look at the fine print and look for clinically meaningful measures. Does it change patient care in a meaningful way? Does it change quality of life in a meaningful way? Because it's great technology, and like any other technology, sometimes it's useful and sometimes it's not. And sometimes it's harmful, and that's what we're coming to grips with now. One last thing, I'm going to squeeze in a fourth.
Bring it.
So a little more than a decade ago, the FAA issued a warning about pilots who no longer knew how to fly planes because of pilot. So they basically said, because we've become so dependent on autopilot, no longer can pilots manage a lot of the aspects of flight that are really critical when you are the one flying. And so they wanted to be sure that people were doing enough training without autopilot. I would say that for clinicians is going to become increasingly critical, because more and more of what we do can be automated. Every time you see a patient, AI can give you the answer. It can help you evolve a plan. It can document the case. If you let yourself become complacent, people talk about de-skilling. I think the way to head that off is just like we do with residents. before you ask me what to do, you tell me what would you do if you couldn't get me on the phone. Then I'll tell you what I think.
Dr. Roy Perlis, for people that want to follow your work, follow your professional journey, what's the best way?
A lot of the things I'm thinking about are in editorials or editor's notes or whatever on JAMA AI. So the JAMA AI website is a great way to see kind of what I'm thinking about, what I'm doing, and of course the best of AI across the JAMA network.
Roy, what do you think the title of our episode should be for our audience?
What I think about is, will AI make things better? That's sort of nothing literary. We could put it in ChatGPT and probably get something more literary, but will AI make things better in mental health? I don't know the answer, but that's what we need to think about.
Will AI make things better? I love it.
The Visible Voices podcast amplifies voices in the healthcare, equity, and current trend spaces. Our team includes Dr. Giuliano DePortu and me, Dr. Resa Lewiss. Find me at Resa Lewiss MD on social media or visit thevisiblevoicespodcast.com. Find us wherever you listen to podcasts and watch our episodes on YouTube. This podcast is for education and entertainment purposes only. The views and opinions expressed by our hosts and guests are their own and do not reflect the opinions of their institutions. Information shared here should never substitute for clinical judgment or for medical advice. Together, we're making healthcare more equitable, one visible voice at a time.